Okay, hello everyone, and thank you for joining today's webinar. This is the fifth such webinar that Pallium is hosting on topics relevant to healthcare teams who are actively leading the response to COVID-19. My name is Jeffrey Moat. I'm the Chief Executive Officer of Pallium Canada, and today's webinar is focused on reorganizing palliative care services during the COVID-19 pandemic. And as with previous webinars, we have assembled a group of experts from across the country, all of whom are palliative care physicians, and each presenter will be taking us through a series of slides. Next slide, please. So we would like to solicit your input and your questions throughout the webinar, and you can do that by scrolling down to the bottom of your screen where you see the Q&A function. And by contributing in this fashion, you are helping to the collection of knowledge. So thank you in advance for doing so. We're also going to be collecting and collating this information and all of this input for future reference out the webinar. So thank you again for your input. So next slide, I've introduced myself, and I'll now turn it over to our moderator and our presenters to introduce themselves. Over to you, Dave.
All right, thank you, Jeff, and welcome everyone. My name is Dave Henderson. I'm the Senior Medical Director for Integrated Palliative Care in Nova Scotia and lead facilitator. It's my pleasure to be part of this today. We've got two great speakers who are going to be walking through their provincial approaches to how they're trying to adapt to the changes that we're seeing with COVID. So I'll move right on to let Doris introduce herself, and then Bob.
Yeah. Hello, everyone. Doris Barwich, and I'm the Medical Director, Regional Medical Director for Palliative Care Services in Fraser Health, one of British Columbia's 5 health authorities, as well as the Medical Director for the BC Centre for Palliative Care. Happy to be with you today.
And Bob.
And I'm Bob Sauls. I'm I have background as a palliative care physician and family physician in just outside of Toronto. And I'm currently working as the provincial clinical co-lead for the Ontario Palliative Care Network.
Thank you.
Thank you. So in terms of declarations of conflict, first off the bat, Pallium Canada, as many of you know, is a national nonprofit organization. We build healthcare and community capacity to help ensure that all Canadians receive timely, effective, and compassionate palliative care. In terms of declarations of conflict, I am paid by Pallium as their Chief Executive Officer. Dave?
Yeah, I don't get paid by anybody.
We all work for free.
Yeah, we all work for free. I'm receiving no funding for this presentation, so no conflicts.
Similarly, for me, I have received no funding for this presentation. I am employed by the 2 organizations that I've mentioned, and I do hold some research funding from CIHR and Canadian Frailty Network.
And I am paid for my role with the Ontario Palliative Care Network.
Very good. So just to look at our learning objectives through this webinar, we're really looking at hearing the description of the role of the Ontario Palliative Care Network, response to the pandemic, looking at key online system issues for palliative care, generating discussion around planning during the pandemic, and key leadership roles for local, regional, provincial, and national groups, and again, as well as looking at Ontario's perspective as well as British Columbia's perspective. And if anybody has any questions about Nova Scotia, I'm happy to chime in the end. As Jeff said earlier, please use the question and answer box at the bottom, and we'll be monitoring that as we go through. We'll basically leave questions towards the end, but I may interrupt if there's a question that's very pertinent at the time. But other than that, we'll look at questions at the end, and please do put your questions in. As everybody knows, that really adds to the richness of these discussions. So we look for lots of participation. All right, we'll move forward.
So I think I'm leading off, and thanks very much, David. So what I just tell you briefly is where the Ontario Palliative Care Network sits in its mandate in terms of responding to the. I'm just going to turn off my phone there. So the Ontario Palliative Care Network was established in 2016 by the Ministry of Health with the intent that it's the principal advisor to the ministry around palliative care, but also its role was intended to be around driving implementation and system monitoring across the province in all the regional entities. So if you go to the next slide, one of the challenges we've faced is that the pandemic hit as Ontario was in the middle of a major reorganization of its healthcare system, so that the Ministry of Health and Long-Term Care, first of all, divided into two ministries, and then established in that white box Ontario Health, which was to incorporate all the major delivery agencies across the province, including the regional structure. And in December, the Ontario Palliative Care Network, which originally reported through Cancer Care Ontario, was absorbed with Cancer Care Ontario into Ontario Health. We're led, and our executive oversight are those three entities in the white box, which are all part of Ontario Health, as well as an external group, which is the Quality Hospice Palliative Care Coalition, which is made up of many organizations that deliver palliative care services in some fashion, and that includes the OMA, the Ontario College of Family Physicians, the Registered Nurses Association of Ontario, et cetera. I think the key piece of this is that on the one hand, this really does offer us some opportunities to help drive planning around this at a provincial level and having access to some of those provincial tables. Some of the challenges here is that this was all being reorganized as the pandemic hit, and there is a slowness sometimes in terms of getting things approved. If you go to the next slide, I think the other piece of our system, which has been very important to us, is that we do have a regional network structure in the 14 pre-existing regions of the province. And this has actually been vital to us in terms of gathering information about what's happening, as also a sounding board for determining what are going to be the best solutions to implement across the province. And we've ramped up our meetings with this group much more frequently. We're meeting every second week, but in fact, we've had some ad hoc meetings as well, which have been really vital to doing this. And I think this structure is an important piece of our planning and response. So we go on to the next slide. So early in the pandemic, we did produce a planning document, which was based off of work done by James Downer and Doris in Toronto about 10 years ago. The CMAJ article that I'm sure many of you saw that was published maybe, I guess, 2 weeks ago now, was also based off of some of that work from James and Dory. We've identified, I think, 5 big areas that we need to address, and it's interesting that even over the last 2 weeks to see which of these areas have actually percolated to the top in terms of the key issues, and I'll go through those in a bit more detail. And if we go to the next slide. So part of our thinking really was, and particularly early on, was planning for an anticipated increase in the volume of end-of-life care, particularly due to COVID. And I think, and again, our perspective on what the scope of palliative care is it really sort of percolates or really sort of gets focused down on end-of-life care in this setting, because what we're really faced with those increased volumes being due mainly to people who are dying from COVID-related illness. We also have had to think a bit about how do we respond in the face of potential loss of human health resources due to either illness or self-isolation. And so in thinking about those human resources, there's 2 areas I think that we've we've spent some time working on is how do we think about the deployment of palliative care expertise in the province, recognizing that even before this, that palliative care expertise is a limited resource, and right now that's even more important to recognize, and recognizing how we use those resources most effectively. One of our sort of initiatives really has been around using those resources to support frontline clinicians. So what we heard, in fact, our first call out was from emergency physicians saying that they were going to need support in terms of working and caring for people with COVID-related illness, and realizing that increased in volume will receive care from generalist level physicians, whether that be family physicians, nurse practitioners, hospital clinicians, ER physicians, and also thinking about the challenges in urban versus rural versus remote communities. So we go to the next slide. So one of our early pieces of work here was really around thinking about how do we best support those frontline clinicians. And a piece of that is definitely providing clinical guidance. And what we were hearing early on was people needed guidance around goals of care conversation, managing end-of-life symptoms. And we've also had a bit of work in Ontario here, which is maybe specific to Ontario's managing expected deaths in the community. One of the other things we've heard is that these guidance documents need to be brief and concise, particularly from family physicians, from ER physicians. They need quick reference information around how to go about managing these things. So we've been, with goals of care, we've been leveraging a number of resources, and just actually recently received sort of a one-pager from a group in Toronto that we'll be disseminating quite shortly. We've leveraged, and what we saw early on, that British Columbia's guide to managing COVID symptoms was a very nicely designed and brief one-pager that was being adapted in multiple places around Ontario. And we've just taken that and sort of coalesced all the Ontario versions into an Ontario-specific version that was just sent out yesterday. I think the second piece of this is, and maybe I've labeled that item incorrectly, but it's more about how do we provide just-in-time support to communities of physicians and clinicians around managing care in the community and in other settings, and I'll come to that in a minute. And we've really been focusing in on emphasizing virtual supports in all of these settings. So maybe go to the next slide. The item that, again, was in our original planning document, which I don't think I need to spend a lot of time, is on access to beds. And our early conversations were focused on the risk posed by a loss of critical mass of home care services, whether that be human resources or medications and equipment. What we're seeing, and I'll come back to that, is the actual risk is not the community, it's long-term care. And that's an emerging crisis in Ontario right now. And that, in fact, the pressures to hospitals and the need to identify alternative sites of care for end-of-life care in hospitals is likely going to come from the long-term care sector. There's also been some concern about underutilization of hospice beds in the province, basically based on reducing the transfers from hospital because of testing issues, but also some families being reluctant to move their family members into hospices because of the visitation restrictions. And that's something we're still trying to get a handle on. Next slide. This was the access to medications in the community has been an issue was raised early on. We've been fortunate that we've been able to achieve a provincial level approach to this with initially establishing a provincial formula, if you like, of what drugs are needed for end-of-life care, and leveraging the home care contracted pharmacies to actually get some data about supply and utilization to actually monitor this in real time. We also identified some of the funding barriers around criteria. David and I were talking earlier about the manufacturer issues are quite nuanced, and there's some real challenges there. And in addition, we've been talking about some of the key equipment needs in terms of drug delivery, so infusion pumps, subcutaneous infusion sets, et cetera. So we've actually been able to achieve at least the beginnings of a provincial level approach to this right now. Next slide. So maybe the thing too I'm going to comment on here is, and this we've been working with this over the last few days, is that in Ontario, the crisis really is in long-term care and by extension retirement homes, which is a large sort of regulated sector. The long-term care homes have got lots of needs beyond just palliative care, and I think what we were hearing today is that many of them are just trying to get through the day and focused on what's right in front of them. They need clinical guidance, and I think that's, we have fairly well in hand in terms of the resources we can provide them. The access to medications and equipment, I think, you know, those we can manage. What's been interesting to hear is that access to palliative care expertise across the province for long-term care is quite variable. Some where pre-existing relationships exist are well supported, and those are in place. Other places have very little. What we're also hearing is that even those places that have those pre-existing relationships, the long-term care homes are not reaching out that much. And again, this may be a feature of there's such a crisis that they're just trying to deal with immediate issues. We are looking at establishing a central provincial line to support long-term care homes, and that's a further discussion we're having today. And then the next slide is, and we've got other work waiting. I think we haven't done enough yet in terms of looking at the needs of Indigenous communities in Ontario, particularly in the north. We have resources out there for psychosocial supports for patients and families. I think we need to do some more work systematically, and then finally support for healthcare workers. And with that, I'm going to turn it over to Doris.
Okay, thank you. So just to say that we really appreciated the work of the Ontario Palliative Care Network. We had looked at various other models for planning, including some of the materials put out by the Center to Advance Palliative Care from the US. But really, as Bob has just discussed, your document was the one that we kind of used, and obviously referencing the article as well that came out in the CMAJ, just so to credit the kind of the work that was the underpinnings for the work that we did in Fraser. So in Fraser Health, just to tell you a little bit about who we are and what we do. So it's a fairly large health authority. 1 in 5 Canadians, 5% of Canadians live in Fraser Health. So 1.8 million people, 12 acute care sites, and it's a mix of urban and rural communities. We have an existing palliative care network that manages the services and liaises with local communities. And that includes 30 palliative care complex care unit beds, 116 hospice beds in the 12 communities throughout the region, and then 10 community-based teams that then provide care and support in all sites, in all settings, in all communities. We have about 25 palliative care physicians, 8 locums under sort of a 21 FTE umbrella, lots of part-timers, and then 3 nurse practitioners in hospice settings. As the palliative care team, we are part of the daily, we have created a palliative care emergency operations committee, so we meet daily to address some of the issues. What are you doing about PPE? What about visitation? Some of those issues that come up, usually people trying to just understand the latest guidance that's come out from our health authority. And as the director and I are also part of the daily regional EOC, and we also have a daily physician coordinating committee. So quite a lot of time spent talking to other people, trying to coordinate, trying to cover gaps and ensure that patients receive the best care possible. As well, underneath those, there's these sort of an acute care surge planning committee, a primary care coordination committee, etc. So what we're finding is people are becoming very specific. Is this for me? Do I need to see this? Because otherwise people are inundated with materials and information from lots and lots of different people. Next slide. We also are lucky to have an advanced care planning team with 6 trained ACP facilitators, a mix of nursing and social work. At this time, we've had no COVID positive staff or patients in any of our units. We do have visiting restrictions in place, 1 visitor a day. I'm just trying to illustrate how this sort of larger planning document got translated down to realities. And we discuss that visitor policy almost every other day because it's really a major deterrent to people coming into hospices, wanting to stay at home, but often care needs exceeding what families can provide. At this time in Fraser, our COVID positive or presumed or suspected patients are all cohorted in special units in all the hospitals. It started off with just 3 hospitals, and now the needs are such that every hospital has a COVID unit. At the same time, we've seen a huge decrease in our emergency room visits. We've seen a huge decrease in our occupancy rates, which were usually running at about 110%, now sitting at around 80%. Critical care, and even at the height of the pandemic in Fraser Health, our pandemic planning has shown that we expect that we will have enough acute care and CCU beds to meet any kind of surge, which I think is a somewhat unusual situation, certainly looking at what other people have had to do to ensure that people are in beds and have access to care. We've always had 24/7 access to palliative care physician support in all settings through various funding mechanisms. And we've always had an after-hours nurse line that's specific to palliative care for patients and families throughout the province, but we run that from Fraser Health and our staff. Next slide. So what's been interesting in this pandemic is that, initially we have sort of an established leadership team with sort of local department heads and so on. And then what's happened is that we've seen some emerging leaders, people who say, listen, I've developed this thing. Would that be helpful to anybody else? I'm interested in doing this. Could that be, and just suddenly you've got a whole crew of people, some of whom I wouldn't have predicted were leaders, but they are emerging as the ones who've taken initiative and to develop new guidelines or connect with others or to serve as a bit of a coordinating feature. So that's been a very interesting thing. Our palliative care teams are functioning quite well, I think, for all of us. I read an article early on that there was sort of a collective grief that we were all dealing with the losses of connection to family and teams, people working virtually, people navigating concerns for their own health, concerns for their health of their families and so on. But it seems like for the most part now, sort of 3-4 weeks in, the teams have kind of come together and seem to be functioning quite well. As Bob had said, in this stage, where in British Columbia, we've really had a fairly flat curve, and even the stats yesterday showed kind of a decrease in the numbers of new patients, concentrating at this phase on education and development of tools and resources for those at the front lines and the specialists that we're linked with, like the kidney care clinics that we're doing and work with renal providers, cancer agency, etc. I don't know if Dave will talk more about this, but certainly the paramedics providing palliative care program that's been launched across Canada now in various phases across the country, that's been a help, because even when patients are staying at home at high risk, the paramedics can provide enhanced backup in a way that wasn't possible a number of years ago. And same issues around long-term care, very few referrals from critical care staff. It's mostly emerged physicians, hospitalists, long-term care staff that are calling. Next slide. So part of what I think Bob's team had identified was that there are these 2 populations, and it was quite interesting when we talked to the 2 co-chairs of our surge planning committee. They hadn't really they'd become so immersed in the COVID planning that they had forgotten that at the same time we're dealing with the usual palliative care patients that we already care for, which is about 6,000 referrals a year. So trying to provide best care possible with this new population on top of our usual. And so the priorities that they'd identified were sort of based on the severity of symptoms, and that no matter which setting patients were in, we would focus on those who had complications with potential reversibility. And that also what's been happening over time is we are especially advocating for the care in our setting of those who are the DNR, M1 and M2 patients. So those are the comfort measures only, and the M2 classification is care within a current location, which is the long-term care patients who are not being transferred out for ICU supports and are not critical care candidates. And then those with moderate severity of symptoms or psychological distress. I think we can't forget that this has been very difficult. Coping is affected negatively in many cases for both caregivers and patients. And some people are just burning out without, the daughter who came in regularly or now can't travel from Ontario or whatever. The caregiver issues, sometimes home support's been less available. So some of those patients are now having to come in and get care because of changes in their support systems. And then really virtual care for those with stable patients, trying to sort of say, hospice patients that are stable don't need daily visits. We can decrease those to twice weekly to have more availability for consults. Next slide. The other thing that we have done, as Bob was mentioning, is to ensure expedited access for physician-to-physician consultation. So bypassing our usual referral mechanisms, which in some cases people found cumbersome and difficult to navigate. So that includes sort of in BC a race line, which is for multiple specialties. So expedited access to consultation expertise. And then after hours through our medical on-call availability funding. We've had to really, we've had some physicians who were off having been tested or having respiratory symptoms. And so at this point, because of those, it's just kind of isolated incidents, we've been able to move people around to ensure usual access to palliative care consultation. And the consideration is there that if we ever do get into the sort of surge, that we would not triage at a community level, but that we would triage centrally so that we could deploy staff to the most urgent needs, anticipating that there might be an outbreak in one community and not very much happening in another. And then obviously virtual care whenever possible, finding that in fact some patients prefer it to talk to a physician face-to-face via an iPad or whatever, whereas otherwise they would receive care from someone who is gowned and gloved and behind a shield, and finding the face-to-face contact better, even though it's virtual. We are not part of an acute manpower plan. I know in some health authorities, palliative care physicians are seen as part of an acute manpower plan in acute care. We've been able to say and make the point that our staff have specialized expertise that we should be utilizing. But there has been a proviso that we may need to become MRP for patients that were consulted on. We also have made our ACP facilitators available to support goals of care and serious illness conversations in the cohorted units. The goal is that for every patient in a COVID cohorted unit with either presumed or actual COVID, they should have had a advanced care planning and a goals of care conversation that's documented and readily available should the crisis come. So I think talking with others about the advanced care planning, yesterday was advanced care planning day, so lots of discussions. This is not about rationing resources or getting people ready for a CPR or no ventilator type conversation. This is still about advocacy for patient and family-centered care. It still involves values and goals, but it also does require an honest conversation about treatment options and likely outcomes, which I'll talk a little bit more about in the next slide. And we found that this has been a large part of what our work has been, is to do advocacy I think people were a little scared by what happened in Ontario in the letter that went to all family members of long-term care residents. And so there's been a reaction in BC taking, kind of backing off of that, saying we don't want to be heavy-handed. We want to not communicate about ACP. It puts us in a bad light. So we've had to really advocate for the idea that it's about patient family-centered care, that we're still doing that even in the midst of needing to balance that with community-centered kind of planning and thinking. We have, as many others have done, adapted our serious illness conversation guide. I know HBCO, Hospice Palliative Care Ontario, and Speak Up Canada have done a lot of adaptations, lots and lots of materials available. And then Vital Talk resources were some of the first that came out around these different conversations, and those are available in multiple languages. So it's kind of choosing what your needs are, and then there's lots of good supports available, obviously contextualized to your own legal kind of frameworks and so on with the Ontario documents and so forth. In our system, we have green sleeves, and we have a visible way on our EMR to access advanced care planning documents. What we've also found is that with the advocacy role, sometimes in this climate, you can get things done that you could not get done for many months or years before. Because if people are asking for it, I need access to this. Sometimes you can push something through very quickly. So don't forget about an opportunity that may be there to create more accessible ACP documents in your settings of care, to get a fax number where documents from community can be faxed so that they're seen in acute care or long-term care, et cetera, et cetera. So just to kind of speak to that it is an opportunity in some ways, and not to miss the opportunities like Advanced Care Planning Day that was yesterday, to just promote this and to promote what we're really all about, which is patient-centered care. Access to beds and supports, as I said, we've seen higher needs, more people staying at home, getting sicker because they don't want to come into acute care or hospice because of the visiting restrictions, but then coming in quite sick. And then also some coming in because they just don't have the support that they need to stay at home safely. So this has been an emerging need, and we've had to advocate again for PPE in community and that sort of thing. Some of these things, because of concerns about supplies, have been slow in coming in some of our settings. We have no access issues at this time, but certainly have talked about the fact that if we get into sort of what we're calling surge stage 4 and then stage 5, we would have to open our units for COVID positive patients, and that likely designate 2 or 3 out of our 10 hospices as COVID positive sites, just because we're imagining that at that time community would be rather overwhelmed. And visitation policies, we keep talking about this. In our hospices that are on the first floor and have patios, you see families sitting outside the window and talking on their phones but still having visual connection, and in other places, because they're on the 3rd floor, that's less possible. So obviously trying to facilitate that as much as possible. I'd be interested in what other people are doing to facilitate this. Next slide. Just going to talk about from a brief conversation we had with critical care, asking what else could we do and what else are we seeing. So certainly the focus for them is on patients who are likely to benefit from critical care supports, younger patients, people who are not frail, people without multiple comorbidities, and who have clear goals of care that include prolongation of life, even with some potential disability. What they were telling us, and this is obviously an N of 1, next slide, is that the usual case is that even for patients who are more elderly and frail, next slide, that this is sort of the typical COVID progression, that you may see symptoms after 5 to 10 days, that there may be hospitalization with a steady decline and then increasing hypoxia and then tipping over very rapidly into a deterioration. So they're recommending in our setting that critical care be consulted as soon as people are using more than 4 liters of oxygen, and anticipating that they may develop severe complications, including ARDS and arrhythmias and so on. And the sense is that because these people, many of them do not have chronic underlying lung illnesses or cardiac conditions, that the hypoxia and the distress they experience is not accompanied by sedation or hypercarbia. So it can be quite a lot of significant distress at the end of life due to both the the alveoli filling up with fluid, but also with pulmonary hypertension and changes in lung compliance, extremely stiff lungs, which make the work of breathing extremely difficult. Next slide. This is the US experience where older adults accounted for, about a third of cases, but a lot higher percentage of the hospitalizations and ICU admissions and 80% of the deaths. And that even with ICU supports, many will not survive. And that even if they do survive, they usually are left with morbidities that may require institutionalization, and that mortality at 1 year is close to 100%. A best case scenario, next slide, for ICU is that they would survive their ICU stay, but that they would have significant rehab needs, and then again would be more prone for major complications, and may need supports to ever go home again, because ideally they've lost their ability to manage ADLs independently. So I think when we're having advanced care planning conversations, it's not just about rationing access. It is also about helping people understand that given their comorbidities, that an ICU stay may in fact not be of benefit to them, and I'm talking about that in a sensitive way. Next slide. Bob has talked about medications and supplies, and I think this is really an advantage of a provincial approach. We've found that that's been quite variable. Some people are having ongoing access to their medications. Others are experiencing difficulties, and it seems to be more with the suppliers. And I don't know if Bob will want to say more about that. And certainly the medications that are often running out are the ones that are used to support dyspnea, and then sometimes the distress, the midazolam or the metronidazole or Nozanan, some of the opioids in the sub-Q forms. Many of the protocols and the crisis protocols that we've developed have been because our one-pager wasn't enough. They needed a quick order set. Then we developed an order set. Then that wasn't enough because people got into significant crisis, and the meds they needed were way more than we were recommending, needed to be given quite often. And so we keep developing new protocols. We are now developing a COVID code protocol, so that they have all the guidance and direction for pulling together supplies on the COVID units, so that if they're running, somebody has this rapid deterioration, they can very quickly respond in a kind of an organized and efficient way. Oxygen, obviously very helpful, but we need to be aware of the aerosol generation. A talk on Tuesday covered this quite well, so if you want to look that up, but no fans, no nebulizers, and to be careful with people on BiPAP or CPAP, and utilizing droplet precautions and appropriate PPE. The other thing that's sort of new now is that sometimes prone positioning in ICUs, or even just changing positions more frequently, can recruit new alveoli and help with some of the distress. Next slide. So just some of the supports available. Pallium, the pocketbook, and the website is being updated regularly. In BC, all the work we're doing that's targeting physicians is also being put on the UBC division website, and are sort of an ongoing resource around some of these symptom management or advanced care planning resources. And the BC Centre for Palliative Care is a site for resources for the public community-based organizations, as is the Ontario Palliative Care Network. And we are developing with Connect Place resources for children. We've just, one of my physicians has just written a book for children around COVID, and we are working with First Nations Health Authority around guidance for remote settings. Next slide. So what is really our role is to ensure compassionate, competent end-of-life care, to anticipate and ensure access to medications. And so we're developing mini drug kits for both our COVID units and communities. That sometimes our partners may need advocacy to get the appropriate supplies, access to tests and PPE. And then our education resources have been huge demand on that right now, and people asking for just-in-time education. Just to develop a PPO that no one knows how to use doesn't seem enough, so we need to be very visible and present. Next slide. And also, as Bob has said, we're just beginning to start to get better at some of these other supports that are needed. Certainly in our health authority, we've given frontline staff the ability to opt out of frontline care for COVID positive patients if they're immune compromised or have concerns about family being immune compromised. A very small percentage of people have done that, usually older physicians with some health issues. And then various things that we're doing around enhanced bereavement support, etc. And I think something we can't forget is that often we do have community partners who are willing and ready to be engaged, but may need some direction about how that's done most effectively. Next slide. And these are just some things that I've sourced from various people, and many of us get lots of things sent to us every day, but just that idea that often people get into trouble if they focus too far ahead in the what ifs, what if, and I think we've learned to focus on one day at a time and to focus on the planning that you are doing. The more people trust you in the current situation, the more they have trust that we'll be ready when and if the worst case scenarios happen. And we need to take regular breaks, enjoy time with family, and do the things that keep us grounded so that we can prioritize and focus on major issues. And one of the things we found is we need to have much more frequent meetings with our teams, smaller, shorter meetings, but to communicate often and frequently, and to really acknowledge the hard work that everyone's doing. This idea of, I know sometimes I felt like a fraud because I felt like I don't really know anything much more than some of my staff who are maybe reading more extensively, but to just show up, be accessible and visible, to sort of deal with issues as they're arising, and to support staff who are, all of whom are just doing their very best. And sometimes we have to set very realistic expectations. Under crisis, not everyone rises to meet expectations. Some people really need a lot of support to continue to provide the care that we need. And that sometimes when we're developing the PPOs, like I know in Fraser Health, we have this tendency to get onto 9th and 10th and 27th drafts. And in this season, it's just important to have it be good enough and to get it out there. And often, sometimes there's some tough decisions to be made in order to lead well. But I think we can be an example for our staff and the people that we're leading, just to show that we can be thoughtful and help others to be thoughtful in the midst of a pandemic. I think that's all we were going to say. And so I think we're now open for questions or comments.
Yes, thank you very much. In our question box, we have a question from Amanda Brisbach. And the question is, in chronic illness patients and in acute care, as a palliative care physician, typically start opioids at a very low dose, dosing long prior to when our specialists are doing for dyspnea. Is there discussion around starting opioids for dyspnea prior to acute respiratory failure, such as morphine 1 to 2 milligrams sub-Q, a couple hours kind of PRN, or around the clock, to allow patients to adapt to the medication as well as relieve dyspnea? We are modifying our palliative protocols, and some of my medicine, family med, pulmonary colleagues are uncertain about this practice. So somebody want to?
I know there's a volunteer to answer it. I'm going to just have a stab at it. I think if there is dyspnea there, I think it is, we're starting people on low doses. And then obviously, I think from talking to my long-term care colleagues, what I've heard is that most of the deaths seem to be very similar to how people have died before. It seems to be more in the acute care COVID units where there are these more rapid deteriorations, and certainly the ICU critical care folk have seen a lot of that rapid deterioration, but that hasn't been the norm in patients with seeming other comorbidities and other illnesses, where again, maybe it is because they're developing that hypercarbia. I'm not sure, Bob, what your thoughts would be, or Dave, what you guys are doing.
I mean, I would agree that I think if the patient is developing symptoms of dyspnea, then I would go ahead and start treatment. And I think, and again, to the point that you raised in your slide, Doris, that I think you need to go ahead and start treatment, but be prepared to titrate rapidly, because some of these patients are going to deteriorate very rapidly, and be prepared to respond to that.
Yeah, so I would agree with that. And we did develop a protocol here in Nova Scotia that kind of addresses it, looking at the mild, moderate, severe symptoms. And then we actually put a separate place in for respiratory crisis, where you can rapidly escalate opioids, but also get into potentially adding in some of the Medaz lamps and things like that to help.
Yeah, that's exactly what we found. It's having, if you get people comfortable with the smaller doses, I think it's easier for them to escalate because they've got some comfort already.
We have another question from Kate Lafferty, wondering about how different regions are utilizing the skill set of social workers to assist in the management. I'm in Western Newfoundland, and we only have 3 cases. Hospital social work are being utilized presently to help with placement community. Oh, we're moving here. I'm trying to read a moving target, so bear with me. But I feel that we should advocate for a different role moving forward.
Our social workers, we have sort of one assigned to each of our 10 teams, and some of them, because we're a network, so we kind of provide advice similar to the Ontario Palliative Care Network, sort of at a higher level, and then the actual staff report to managers locally. And so in some cases, they have been pulled into more frontline work, similar to what I'm reading here, around placement and community supports. We are also trying to advocate that this not be at the expense of the specialized expertise that we have. And certainly with the visitation policies and some of these other issues, there is a lot of family distress right now, and different issues around just sort of end-of-life care that I think our social workers are skilled and potentially more have more expertise. So it's kind of a balance around what are the needs and ensuring that the expertise is there to manage the things that we're really good at.
And I think the thing to add, again, part of our discussion this morning was around providing that provincial level access to expertise. And of course, people tend to focus on medical expertise. And in long-term care, for example, general internal medicine is providing that support. But we've identified that that expertise needs to include social work in addition to medical support, because some of those needs are going to actually be that psychosocial care and direction that, in particular at the moment, long-term care needs.
Yeah.
If I'll just comment again on the Nova Scotia experience, and I'd recommend to any of the social workers out there, I see the role and the work of social work should be extremely high right now. And it's only going to become so much more important as we move forward. When you look at the societal changes that are happening, just the isolation that's happening, the families that aren't getting to have normal closure, if there is such a thing, for death and dying, not being able to be present with family when someone does die. So there's issues to be dealt with now. There's issues to be dealt with in anticipating these moving forward. And there's certainly going to be issues with grief and bereavement. May certainly be much more complex as we move forward. So I would recommend, especially in the smaller provinces, like here in Atlantic Canada, try to reach out to your other social work colleagues in the province and try to start connecting and looking at some strategizing around how, as a social work community, you can start to pull things together and develop some strategies on moving forward. I know there is a palliative care social work group through the Canadian Hospice Palliative Care Association, and it may be worthwhile even to reach out and through that group, perhaps some either provincial or national things can be working towards that as well.
I think the ECHO that we have, which is this sort of moderated platform around issues for psychosocial care providers, has been very helpful as a forum where people can connect with others, because I think sometimes our social workers have felt quite isolated. So I think those are really good points, that the more we can connect people in this season, the more we can share ideas. I think that's how people then, feel more empowered to kind of implement great ideas across a broader forum.
I'm just going to pick up on, you said that earlier, Doris, that I wrote down, was the idea of emerging leaders. And that we've seen the exact same thing here, is that people that we weren't aware of are sort of emerging. And part of my daily work here is connecting people in sort of a rapid development cycle. There's a great idea that we need to actually get out more provincially rather than having it stay in its local setting. And so connecting and identifying those emerging leaders and networks of leaders, I think, is a very important part of the role.
Yeah.
All right, I have a comment from another Newfoundlander. How's she going there, buddy? Susan McDonald. With all the emphasis on the end-of-life issues with COVID, we need to remember to continue to advocate for palliative care early for symptom management as soon as the crisis is over, lest the gains we've made over the last 20 years be lost. It's interesting, Susan, that quickly reminds me of being in a home in the last couple of weeks with a gentleman dying, and his wife was there and his daughter was there, and his adult daughter, we were talking about some of the limitations, needing to wear the masks and the restrictions in hospital and so on. And the daughter kind of looked at me, she said, sometimes I just wish people would remember that people are dying from other things other than COVID. So it just really resonated with me and stuck with me that, there is so much focus on COVID, we can't remember the other people that we've normally been looking after at the same time.
And I just wanted to say for Susan, I think that what we found is that initially we were seen as quite peripheral. And like in Vancouver Coastal, they've actually moved the palliative care units out of hospital into sort of, rehab facilities or into hospices. And we've really been advocating with some of the work we've done that we have quite a central role and expertise that needs to be represented. And I'm hoping that will also give us credibility when we go back to the sort of palliative approach and early palliative care kinds of issues that we're seen now as more integrated parts of the system in a way that we weren't previously. It's been interesting to see how some people saw us very siloed. I was in Fraser Health, left to do something else for 5 years and came back a year ago. So it's been interesting to see. And then so I'm hoping that will translate into this greater advocacy role that you're talking about.
Okay. Here's another very good question from Jill Elaine Torrey from Ontario. In contrast to BC, which has the First Nations Health Authority, Ontario is dealing with federal, provincial, and regional local jurisdictional issues with regards to First Nations health services. In the current situation, this is exacerbated. Has the Ontario Palliative Care Planning been addressing First Nations issues in general, and at this time, and if so, how?
So I think I should answer that. There's been some work around palliative care in First Nations communities or Indigenous communities in general in Ontario that's predated this. It's been hampered because of losing some of the provincial level leadership that was occurring through Cancer Care Ontario. And at the moment, most of the work that we've identified is going on within the regional networks. So those regional networks which have sizable Indigenous populations are doing some work there, but we've called that out that right now that I think this is a community at risk, and that we need to have a provincial level strategy or approach to this now, and that we need to address that, because while we're dealing with a crisis in long-term care right now, I think the next potential crisis could be in First Nations communities.
Thank you, Bob. All right. Let's see here. I know we're running out of time here, so I'm being a little bit selective. From Valerie Cooper, in the US, we're using palliative care teams to help in critical care areas to provide communication support for families and the care teams themselves because of the expertise they can provide in these hard, difficult times. So are we seeing that in Ontario and British Columbia?
Sorry.
I think we've tried to avoid being lumped in with just general providers and trying to keep our distinctions and our ability to consult. So our linkages have been more in terms of providing like developing resources or enabling access to resources, things like that. And so I think over time, it's kind of like critical care kind of is dealing with their issues in their ways. And they've had, one of our physicians is a respirologist and a palliative care physician. So she kind of bridges the expertise. So there hasn't been a lot of consults from critical care to us as the general pool of palliative care providers. They're more to Shalini because she's got the dual expertise and she's, does her shifts on the critical care units. So in our settings, we haven't seen our teams more generally being pulled in. Ours is more the support for people in the units in the hospital, the people who either won't be going to critical care, have chosen not to go there, and then the community is kind of where we've mostly been using our expertise.
And I would concur that that's, I think, the similar situation in Ontario as well.
Yeah, and same really in Nova Scotia as well. I know we're coming down to the last few minutes, and there's a good question here from Pam Mansfield that I know everybody really, really struggles with. Pam's from New Brunswick. What are others' thoughts on visitation? Is there any way to allow more visitors? Very hard for families to choose just one or two people that are allowed to visit. I joke about that. I've got 4 kids, and you just pick your favorite kid and you say they're it's easy. I don't know why people struggle with that. No, well, obviously kidding, but there's a lot of it.
I know that one of the hospices in BC, or one of the areas, they're swabbing everyone on admission. And if you have a designated visitor, they're talking about, can we just swab them? And then if they're negative, then we don't have to be so concerned. Obviously, real concerns about your testing guidelines and how we would start to just swab asymptomatic people, that's not really practical. But if we could do it, you would at least know they're all negative. We don't have to worry, but I don't know until there's sort of more widespread immunity. I'm not sure.
Yeah, and the challenges are, and I start to read more about it here lately around some of the false negatives.
Yeah.
And then, just that lag time of when you may have been exposed to when you're actually going to test positive. So we had a case like that in Nova Scotia where someone tested negative. They were taken off isolation only to test positive several days later. And it meant that several healthcare professionals had to be off for 14 days while they were being tested and so on. Yeah. I know I read in Ontario that they were looking at a test that only takes about an hour to get back. I don't know if that's been seen in
It's not it's not out there yet. I think the other thing is that we've been a little bit cautious about providing very specific advice around this because and what we saw early on is people providing all sorts of advice about infection control that wasn't coming from Public Health Ontario, wasn't coming from provincial level resources, and leading to a lot of confusion. And so we've been cautious about providing some very specific advice that's not in alignment with what Public Health Ontario is recommending.
Yeah, and we still face the question every day. And really, when you look at the whole issue around visitors coming in, it's such a multi-faceted issue, because if the patient is obviously weak and in a weakened situation, so they're at risk of getting it if they are exposed. And so there's the issue for the patient, but there's also the issue for the staff. So it's a matter of protecting the patient, protecting the staff, protecting families. And this is just such an extraordinary time that, the guidelines are there, and unfortunately, I think we have to stick with them. And it's completely counterintuitive to what we all believe and what we do. So it has been a huge challenge for many, many people. So we've been trying to use the virtual tools to help people visit that way as much as possible. Sorry, go ahead, Jeff.
No, I was just going to say, it looks like we have to wrap things up. So I want to first thank all the participants for being part of today's webinar. Thank you for your thoughtful comments, your questions, very much appreciated. And a huge thank you to our panelists, to our moderator, for the time that you folks put into developing the slide content, your time on today's webinar. Thank you. Couldn't make these happen without you. So thank you, Bob, Doris, and Dave, for your time. For everyone, just to reiterate, we'll be collecting and collating all of this information. We'll be making it available online along with a recorded version of this webinar, and you can share that widely with your teams and colleagues. So again, thank you everyone for your time, and I hope everyone stays healthy and safe.
I'd just like to thank Pallium for making this available to all of us across the country and all the good work that you do.
Thanks.
Thank
Dave.
you.
Yeah, thank you.
Thank you. Take care, everyone. Stay safe.
Bye-bye.